recall, last week I presented to you as the key segment in remembering where things are in the brain stem. If we look at the pons, front, with the cerebral peduncles going up, the midbrain, and the groove here in the midline medulla, the pyramidal tracts coming through and crossing the bulge of the nuclear olive, and the outline of the medulla like this. There's down the spinal cord. Put that to the front. The basis pons is obscuring all of the important segmental stuff behind, but the critical boundary that we see here is the pontomedullary junction, because this is the line along which the 6th, 7th, and 8th cranial nerves come out. The 6th and 7th being the motor, and the 8th being sensory. But this, although they come out at this level, the segmental components are behind the olive, and so the segment itself is sort of the caudal half third of the tegmentum behind the basis pons. The 5th nerve, just for orientation, will be coming out laterally here, about the middle of the basis pons, and of course the 3rd nerve is coming out of here, immediately in the caudal midbrain, and the 4th nerve coming out some back on the side. If we look at this more conveniently on a mid-sagittal view, we'll see something like this. Midbrain, the pons, the medulla, the junction of pons medulla and pons midbrain, the basis pons compressing the tegmentum behind, and about halfway behind the basis pons we have division between the anterior and middle hindbrain segments. Posterior hindbrain down here. In a cross-section now, through the middle hindbrain segment, we're going to have, instead of the olive and pyramid, we're going to have the basis pons. So if we look at that in a mid the 4th ventricle now is going to narrow down the basilar groove, and a big structure off to the side is going to be the continuation of the basis pons into the cerebellum, which is why it's the bridge between the two cerebellar hemispheres. And of course most of that is made up of fibers whose cell bodies will pick up in the 3rd stage of the cerebellum, but are crossing as pontocerebellar, middle cerebellar peduncle fibers. So here we have tegmentum and basis pons, and these pontocerebellar fibers are coming up into the cerebellum as the crossed middle cerebellar peduncle. Running through this suprasegmental addition will be fibers of the pyramidal tract that we saw here. We have peduncle pons crossing And they will be broken up into islands, tracts, fibers, cross-cut, that are running at right angles, of course, to the horizontal fibers of the basis pondus. So those are the two major suprasegmental structures that are obscuring grossly the segmental stuff behind. So just as we had in the posterior hindbrain, very distinctive landmarks, gross landmarks, inferior brown effect, so we have up here in the middle, and we'll see it again in the anterior hindbrain, a very distinctive basis pondus, composed essentially of two major systems, horizontal and descending fibers. Now the segmental stuff has a medial group of cells whose fibers come out ventrally. There's a sixth nerve coming out of the junction of pons and medulla and ascending in the subarachnoid space for a while, penetrating through the dura to run to the epidural, but still intracranial region, up to go out through the cavernous sinus related to the carotid artery and picking up the third and fourth cranial nerves, and the first and the fifth, and eventually going out to the lateral rectus muscle, through the orbital foramen. And so it has a rather long course related to a lot of interesting neural and extraneural structures that allow it to be damaged in a variety of diseases. So sixth nerve palsies are frequently of localizing value in terms of where the lesion is, from the nucleus through the pons into the subarachnoid space, dura, cavernous sinus, and so on. The petrous ridge up in here, so it's liable to be damaged in a wide variety of diseases. Unfortunately, it's also liable to be dysfunctional in another wide variety of diseases that seem to have in common increase in cranial pressure. So you have it as a false localizing sign frequently. And the only one who's tried to explain that was old Dr. Cushing, about 1914 or so, somewhat before my generation even, when he said that the artery, the internal auditory artery, if it was superficial to the nerve, could compress the nerve against the basis pondus and produce, be responsible for the false localizing sign of accompanying generalized increase in pressure. One would have thought that in the intervening decades, if someone would have tried to confirm that or deny it, but I don't know of any such attempts. So the sixth nerve nucleus is an important structure, medially placed and exiting medially as we would expect nice medial neurons to do. Any questions about the sixth nerve? Of course, its main function as part of the sentinel segment in forcing the lateral rectus muscle to contract, turns the eye towards the sound, which the ear is being focused by the seventh. So there's the sixth, seventh, and eighth cranial nerves that remind you of what's in this segment.
When it comes out of brainstem, where does it travel to get to the 6?
It comes out of brainstem into subarachnoid space for about a centimeter or so, which is where we usually cut or tear it. It penetrates the dura and then runs in the epidural space over the petrous ridge as it enters the split in the dura, where they can run a sinus, and then runs simply straight forward past the carotid artery into the orbital fissure with the first division of the trigeminal and the third and fourth nerves. And once in the orbit, it goes to the lateral rectus muscle. I probably left out some details. What was the specific point you wanted?
That was it.
That's it? Okay. Any other questions on the sixth nerve? Of all of the extraocular muscle functions, this is by far the simplest. One nerve, one muscle, one simple function of turning the eye laterally. So much for medial muscles. Laterally, we have another group of large motor neurons, the seventh, facial. These have a rather curious course because they course medially around the sixth or abducens and come out laterally as the seventh cranial nerve. And these will take a long, somewhat tortuous course. They first will enter the internal auditory meatus, which is the beginning of the facial canal. They will go through the facial canal and bend down and exit the skull through the stylomastoid foramen, and then outside of the skull we'll go to a variety of facial muscles which we'll come back to as we need it. So this is voluntary motor activity for control of facial muscles, forehead, around the eye, and lower face. And this course of the internal genu and out here the external genu, which is where the geniculate ganglion is going to be, get to the sensory plate. This curious course led the early anatomists of the 1800s to not know whether it's crossing or staying on the same side. And we'll shortly see when we come to one of the sensory regulators mentioned the other day, the superolive olivocochlear bundle, will cross and contribute to that kind of gross, low-power confusion of fibers. So, medial and lateral groups. Any problems so far? The third group, of motor neurons up here, medial to sulcus limitans, as cells that are autonomic preganglionics. And these come in two types, whose interest is easiest to remember in terms of a relatively rare syndrome, the syndrome of crocodile tears. Because the two major functions here have to do with salivation and tearing. The salivary component comes out past the genicular ganglion, makes a detour around the tympanic membrane as part of the chorda tympani, and exits the skull through which one? Petrotympanic cleft or something like that. That's the right color here. To go to the maxillary gland, ganglion, and postganglionics to submaxillary and sublingual glands. Salivation. The other cells up here in a nucleus at a slightly different level, very similar function, that having gone into the facial canal, now have to take off and back into the skull through what foramen, right? Hiatus of the facial canal. And then run as the greater superficial petrosal nerve to get back inside the skull. Now they got to go out again until they go out with the carotid artery through the foramen lacerum. Carotid artery. Picking up some sympathetic fibers, the vidian nerve, and on out to sphenopalatine, ganglion, and postganglionics, the lateral. And as I said, the main reason for associating these two functions, the main reason I can see anyway, is the syndrome of crocodile tears, which occurs when we have a fracture through the facial canal or some other destructive lesion that would usually produce a facial palsy as well, but transects these two autonomic systems. So when they regrow, they grow back, at least in part, to the wrong place. So that when one wishes to salivate, one cries, which is the mythical story of the crocodile who cried because he was sorry he had eaten. The difficulty being, of course, the crocodiles don't have tears, so they can't cry, and they probably enjoy eating them in the first place. That at least serves to remind me that there are these two autonomic functions in this dorsolateral part, autonomic pregangliotic part of the motor plate of the middle hindbrain segment. Any questions? Motor plate then is complete with medial, lateral, and dorsolateral components. Then we have to remind ourselves that there's another way of looking at motor plate from a functional point of view. We have the two medial lateral alpha motor neuron systems. We have a smaller autonomic system, and we have the third component, which is the sensory regulator system. One of them we've seen before as spindle afferents. And those are regulators of spindle afferents, the gamma motor system. Those we don't know very well at all in relation to 6th and 7th cranial nerves. I don't know much about the spindle afferents today either. So I can't locate those. But there is a nucleus just in front of the 7th motor nucleus, which is a mixed bag of cells, partly, just schematically I'll divide it here, partly association plate that will be a relay part of the auditory system we'll get to in a while. But other cells in this complex little nucleus are final output type cells of the descending auditory system from auditory cortex back down through geniculate and colliculus and reticular formation, ending on these cells whose fibers come up and cross, exit as the olivo-cochlear nerve bundle, which goes out to the hair cells of the organ corti and provides for presynaptic inhibition of that very first synapse. Now that reminds me that I've forgotten to tell you about another little muscle, nerve, piece of the facial, which comes off to the stapedius. Got the right place here. To the stapedius. These two systems are by no means equal in their ability to inhibit sound. The olivocochlear is far and away the most effective. The stapedius is supposed to stabilize the stapes and supposed to prevent damage to the inner ear from high intensity sounds. The only trouble is that reflex comes in after the sound. And it turns out that the only effect that the stapedius muscle contraction has on sound is to make a click sudden contraction, short duration. And if it stays contracted, it has no more effect. So it's only when it briefly contracts, makes a click, that is followed by brief inhibition. But the olivocochlear does a much better job. And while I'm thinking about inhibition of hearing, the tensor tympani, which is a piece of the fifth nerve from the next higher segment, is also credited with being able to protect the tympanic membrane from high intensity sound. It does, as far as we can tell, physiologically almost nothing. So the three little things that relate to inhibition of sound, the olivocochlear is by far the most important physiologically. It's tedious a little bit, and the tensor tympani grossly overrated. But anyway, this olivocochlear is one of the motor plate elements that regulate the sensitivity of a sensory environment. We'll be coming to the sensory environment just after the music plays in a minute. So I have to think of something to say for a minute so we can take a short break. Any questions on this motor plate so far?
Where does nervus intermedius go?
Nervus intermedius? Nervus intermedius is a mixture of these autonomic and olivocochlear fibers and sensory fibers we'll be coming to in just a moment. Since most of them relate to the seventh nerve, I usually don't split the seventh nerve. But nervus intermedius, intermediate between the motor seventh and the sensory eighth, has this mixed bag of other sensory components and autonomic components. See that I haven't put in the seventh nucleus on my mid-sagittal view, and of course it's going to be sitting out to the side here laterally, not supposed to be in line, but ventrally, with its fibers coming around and coming out again towards us as it comes out through the ponomedullary junction. So I can't draw it very easy on this diagram. The sensory plate has a ganglion out here around which the motor fibers so far have taken a knee-like bend, a right-angle bend, the geniculate ganglion, and it has small fibers that exit to supply a small piece of the external ear, deep, posterior, and come in and branch rostrocaudally, giving off secondary collaterals to the nucleus of this tract, which is coming down from the anterior hindbrain, mostly trigeminal fibers, and as a small pain component of the major trigeminal spinal or descending tract. trigeminal. This is another little example of how the pain fibers come into this segment, branch horizontally, and join the major pain fiber system, come into the next higher segment. We saw the same thing in the posterior hindbrain segment as these small fibers join together and overlap the spinal pain fiber system into this hour's tract. So we have all these running in one major small fiber system, from anterior hindbrain down to the spinal cord. We don't have any large fiber system in this segment. At least not in this ganglion, not in the geniculate ganglion. There probably are some in the mesencephalic nucleus of the trigeminal that subserve the spindles related to the 6th and 7th muscles, nerves, and their muscles that enter through the major first division of the trigeminal. But we don't really know that in the human. As we know they use the first division of the trigeminal, we don't know where their cell bodies are. We seem to be like the goat in that sense, having a trigeminal root entry for spindles, in contrast to the cat, which uses the 6th nerve for spindle afferents to the lateral rectus muscle. So we'll skip that one, and we come to now a mixed bag of in-between size fibers. One of which has cell bodies in the geniculate ganglion, a peripheral course to the tongue with a sense of taste, and a central course to the solitary tract with secondary collaterals to the nucleus of the solitary tract, a system that joins the major components of the solitary tract from the posterior hindbrain that we talked about the other day, afferents and part of the GI tract. So those are two systems that should be familiar to you from the previous segment and from the next segment. The next collection of in-between size fibers are the two major components of the 8th cranial nerve, auditory and vestibular. And here we have an entirely different set of sensory fibers. They are located in different places from this genicular ganglion, and they are bipolar cells instead of these unipolar cells. And so just schematically, I'll put them out here as bipolar cells with afferents coming in centrally to specific regions of the segment. The cochlear fibers. I'm getting a little cluttered here, so I'll draw them over here somewhere, and I'll change my colors too. Let's take the cochlear fibers first. Bipolar cells with a short peripheral branch coming into relationship to hair cells of the organ of Corti. A central branch coming in to end on a nucleus which rides along the path572L05midhind junction as a dorsal and ventral cochlear nucleus. Space there. Let's try it here on that same horizontal section. Midline, basilar groove, ventricle, tegmental boundary, middle cerebral peduncle, and near the path572L05midhind junction, down, sweeping around the lower level of this one, we have the dorsal and ventral cochlear nuclei, into which these bipolar cells are going to synapse. So we have a very special afferent transducer, the organ of Corti, a very special kind of neuron, and a very special association plate that we haven't seen before. And this association plate nucleus, dorsal ventral cochlear nucleus, is going to give rise to secondary ascending afferents for hearing. It will go to a whole series of nuclei in the brainstem, one of which will be a piece of the superior olive. But it'll be easiest to talk about them when we get to the inferior colliculus, which is where they essentially all will end. And that'll project on from inferior colliculus to medial geniculus and so on. Suffice it to say for the moment that those second elements are going to be roughly half crossed and half uncrossed, so that for all practical clinical purposes, the only place you can get unilateral deafness is from the nucleus on out. that lesions involving the nucleus are probably the rarest, and most of the lesions are essentially peripheral. Tumors related to the eighth nerve, trauma to the facial canal, and even further out in the auditory system, involving the external, middle, and internal ears themselves. So let me leave it at that for the moment, unless there's some other questions about auditory system in general.
Back up a second. The small fibers from the seventh nerve, what are they coming from?
These are pain fibers coming from deep in the ear, from the external ear, or deep in down near the tympanic membrane. And they would be responsible for the pain of geniculate herpes and the eruption of blisters in the ear with that disease. Any other problems? Parallel to this, it comes in, and we can pick it up over here as coming from other hair cells of the vestibular apparatus. These come in to end on a nucleus that so a diamond-shaped nucleus, the vestibular that one is stuck with the dust. So vestibular nucleus will be much more medially placed, still lateral to sulcus limitans. Will be much more rostral-caudally elongated, but actually we'll see a large amount of it down in sections through the medulla. And these bipolar elements will come in and synapse on one or more components of the vestibular nucleus. The vestibular nucleus is a rather complex structure with more than four subdivisions, of which I've shown at this level, rather high up in the pons, the superior laterally, with the lateral, medially, the medial one, and the inferior or descending nucleus. So, This system now has two major components, because there are two different kinds of hair cell systems related to this input. One is the gravity system. Gravity receptor. To appreciate gravity or changes in our relation to gravity, it would be nice to have fluids. On top of these hairs, pressing down, so when you go down away from them, there's less stimulation. When you go up against them, there's more stimulation. But they are only being stimulated at the beginning of this movement. This is the system that is responsible for seasickness. And for those old salts who believe they can't become seasick, it's just a question of time and a nice slow roll against the horizon, and I gather that even the hardiest sailor can become seasick. And some of us can become seasick even without being on the boat. So there are all gradations in susceptibility to motion sickness. As Dr. Shaw learned some years ago, when he went out salmon fishing, with his buddy Bill Sada, who offered him some Italian, I guess it was, in those days. He said, "Oh, I don't need it." Thinking that his vagotomy for his ulcer would have cured him, and forgetting that it had nothing to do with the vagus. It's all vestibular affairs, and he got sick as a dog, I understand, and was reminded of his neuroanatomy in a rather embarrassing fashion. But anyway, the stimulus for this is a slow horizontal tilt. And given enough time, even the strongest individual succumbs. It is a system that's completely separate from the other non-otolith vestibular component. This other one, the semicircular canal system, in contrast to the utricle, is macula, where these hair cells noodle the slide. Semicircular canals are designed to keep the eyes parallel, so track medial, lateral, up, down. As you move, or as the environment moves, it's the classical driving a car or riding a railroad car and watching the telephone poles go by. You visually grasp on one and follow it, move back, grasp on the other and follow it. And so the semicircular canal system is designed to show you nystagmus when the patient has a lesion or disease involving the semicircular canal system. The two systems, gravity receptors and semicircular canal system, are totally independent. So when you see a friend of yours being seasick, if you look closely, you'll find they don't show nystagmus. Of course, it's not the easiest position to imagine yourself getting into, as your friend is vomiting in your face, but I'm told that they do not have nystagmus. The semicircular canal system with the ampullae are just hair cells that are waving in the breeze. And as the head rotates, an angular rotation sets off these hairs to move in one direction or the other. First being caught and then becoming stable as the rotation continues, and when you stop, the inertia of the fluid inside carries the hair cells continuing, so you tend to get an on and off type of stimulation as rotation starts and stops. So it's the angular acceleration and the acceleration that stimulates these non-otolith hair cells. The connections of the vestibular nucleus for the two systems, gravity and semicircular canals, are also entirely separate. The gravity system tends to project into the oculonodular cortex, so that among techniques of preventing motion sickness is removing the flocculus bilaterally, which is not applicable to most human situations. But we see this in its purest form, probably, in the human, in the syndrome of the medulloblastoma, where it's the nodulus component, posterior vermis of the cerebellum, where the tumor usually begins, and the kids come in with difficulty in balancing against gravity, a wide base gait, truncal ataxia, they can't balance even sitting on the edge of the bed, but in general they do not show nystagmus.
They would get seasick.
Sorry?
They would get seasick.
And I guess they would not get seasick. Haven't tried that as a test. Nor do they generally show incoordination of their extremities. Unless the tumor gets to be bigger. But in its pure form, it's essentially a pure gravity dysfunction. The ampullae and the semicircular canals project the vestibular nucleus, and they then project to extraocular muscles, nuclei, third, fourth, and sixth, in a way that is appropriate for maintaining the eyes parallel, either vertical or horizontal. And those paths are largely through the medial longitudinal fasciculus, which is a system of fibers running medially just beneath the floor of the fourth ventral, interconnecting third, fourth, and sixth. And it'll be easier to talk about that system when we get to the midbrain and have the other extraocular muscles in place. Suffice it to say for the moment that the MLF is essentially unrelated to the voluntary conjugate gaze system, which is a descending tract that lies a few millimeters lateral to the MLF. So when we get to the midbrain and talk about all the interesting syndromes of extraocular muscles, we'll clearly distinguish between syndromes of the MLF and of conjugate gaze pathways. I've left out some major statements. What did I say 9 years ago, Mike, that I've left out? Right. Thought of it. The lateral vestibular nucleus gives rise to the lateral vestibulospinal tract, which is the major descending system that comes down to the gamma motor elements. That innervate the ends of the muscle spindle system, whose large fibers we've talked about before. And this system is largely the intersegmental gravity to gamma elements that is responsible for the increase in extensor tone when you decerebrate an individual. And you have a preparation, it's almost all that I've drawn on board here, just pure brainstem preparation. This vestibulospinal system is accentuated, made hyperactive, so that the extensors, anti-gravity muscles, are about as active as they can be. You do this to a cat by cutting through the midbrain rostally, and they will stand up, just like a toy stuffed cat. Stand. And that's largely due to the gravity system and the lateral pseudonucleus and the descending intersegmental influence upon the gamma efferents. And one can show that by cutting the dorsal roots, eliminating the spindle afferents, to show that it is a segmental reflex that has been made hyperactive. And one can show that there's a descending a series of descending systems that facilitate the vestibular nucleus by chopping the brainstem progressively towards the vestibular nucleus, and the system collapses when you destroy the vestibular nucleus. So, that's a rather brief tour through a very complicated, it's the most complicated segment we have. It has essentially all of the major elements, sensory motor association plates, mediolateral and dorsolateral motor components, with at least small and medium size, ordinary type sensory elements, genicular ganglia, with the large component probably displaced up into the mesencephalic trigeminal nucleus, and then with a couple of other very important special sensory components, auditory and vestibular, and the vestibular itself with two major, quite different components. So you could remember those again as a series of three, one cochlear and two vestibular elements. Any questions? Okay, well tomorrow then.